for your kind introduction. It's very honorable to be here as a last speaker. And in this talk, I'd like to discuss the current conventional CT angiography we are using, and as well as the next generation CT technology. To be honest, it's a bit difficult to clearly define what counts as a next generation, since the systems we use different greatly depending on the vendors. And some hospitals have already adopted photon counting CT. And so for the sake of clarity, I will refer to the systems I currently use from several vendors as conventional CT. And I'll begin by discussing these first. Recently, several of my friends, colleagues, including me, went for health checkups. And interestingly, they all, including me, had one same finding in common, the C-spine disc herniation. As a radiologist, I can tell you, when the lesion isn't clearly visible, even if we zoom in as much as possible, sometimes all that happens is that my neck gets longer. But the clarity still isn't there, and coronary plaque is no exception. But it's not always the case, of course. Some vendors already provide excellent image quality, even now. Not all the time, but in many cases. One good example is Siemens Force. I love the vendor. And still, stent lumen visualization is really clear, making the images interpretable in most cases. But there are times when we hesitate at the blooming artifacts from calcified plaque. Okay, let me check a point option. Okay, yeah, here. Okay, yeah, the calcified plaque remains a daily challenge, like this. And in the past, we used to classify the plaques as mixed or non-calcified. That classification was based on the 2011 SCCT guidelines. But over time, the criteria have shifted, and now there's a recommendation to use the term predominantly calcified, non-calcified, like this. Recommendation terms are here. So this is an illustration from a previous ASCI, Asian Society of Cardiovascular Imaging, discussion among Asian cardiac imaging specialists here. And it raises the question, partial calcified and predominantly calcified. It almost feels like wordplay, almost the same, right? But let's think about what the actual difference is. Technically, if there's a calcium, we should call it partial calcified. Yeah. The one top, at the top, has just a tiny speck here. Maybe you can't see. Speck of calcium, so we describe this as a partially calcified, but it's also partial calcified lesion, right? But if we use the term predominantly calcified and approximately 50% threshold, these four examples can be divided into two categories: predominant non-calcified or predominant calcified lesion. So now you might ask, why are we suddenly talking about plaque while discussing CT imaging quality? But it's because in order to make this kind of classification clearly, the plaque has to be clearly visible on the CT scan images. The degree of stenosis also depends on clear plaque visualization for accurate assessment. Of course, even with conventional CT scan, we are still trying to categorize lesions as best as we can. And cross-sectional area studies are still being actively conducted also in our hospital. The CONFIRM registry was one of the most prominent registries during the early days of coronary CT angiography. It was led by James Min, who later went on to found Clearly, and a company specializing in coronary plaque analysis, as you know. The numerous studies have been published from CONFIRM registry, including a notable study that applied machine learning to optimize cardiovascular risk prediction. Conform 2 registry is actively enrolling patients now, and this time incorporating Clearly's AI solution in that study for coronary plaque analysis. David Newby from Edinburgh lead the Scott Hart trial 10 years ago, and it's the first landmark publication in The Lancet demonstrated that CCTA-based care might reduce the future risk of myocardial infarction compared to the standard of care. The five-year follow-up results published in the NEJM further clarify the superiority of CCTA over the standard of care. And the Scott Hart data also contributed to demonstrate the prognostic value of non-calcified plaque burden in that followed study. In 2022, a team led by Damini Day utilized Scott Hart data to externally validate the clinical utility of AI-based CCTA analysis. And the AI-based system they developed showed 87% agreement with CADS-RADS categories that we usually do on using clinically, as determined by expert readers. And this year, the 10-year follow-up data from Scott Hart was published in The Lancet, showing that the CCTA group had better clinical outcome despite the similar rate of coronary revascularization. And this study was conducted at our institution to evaluate how well Siemens AI for coronary analysis predict indeterminate region, coronary regions, coronary stenosis, and it showed moderate correlation between the quantitative CT angiography and invasive FFR, even in intermediate lesions. In most cases, AI-driven stenosis measurement showed good agreement with invasive coronary angiography, like this. And false negatives or false positive cases occurred when the lesion overlapped with a vein or some artifacts like blooming artifacts or image noise such as motion artifacts. Here are some examples where lesions overlapped with other structures, venous structures, or were affected by motion artifacts here. And here is a case with a large calcified plaques caused significant blooming artifacts, making evaluation very difficult. Efforts to quantify plaques have been ongoing for many years, primarily by platforms like HeartFlow and Clearly. And recently, there have been a shift toward calculating total plaque volume using our conventional CT angiogram images. And studies now show that cardiovascular event risk differs by the plaque volumes, and there is even a growing trend to use total plaque volume for staging coronary arteries with coronary stenosis, with evidence showing that even event risk increased with higher plaque stages. That's much like a cancer staging, isn't it? And the use of AI in coronary CT is not so much next generation because it's still ongoing and evolving hot topic. And now, what if we combine this impact with a photon counting CT? This is an image I created using DAL-E to express how I felt when I first saw the photon counting CT images. Here, open the window, and then clearly visible. Still not visible area is in the center, but very clearly visible. And the ultra-high resolution feels like that it might actually stop the progression of my neck disc herniation. And here you can see the clear high-resolution images. This slide is from Siemens. Conventional CT involves a two-step process, converting X-rays to light, then to electric signals, leading to some signal loss during the process. It also has a dead zone, like here, caused by the scatter grid, where signals are not received in that area. In contrast, photon counting CT directly converts X-ray into electrical signals, eliminating even a very small chance of signal loss. And it uses a conductor without septa here, and it supports multi-energy imaging, offering significant advantages. Just look at inside of the stent here. It's incredibly clear, isn't it? And this is truly crazy volume rendering image quality. It can accurately show the plaque length and degree of stenosis within the stent. So currently, we simply report the presence of in-stent restenosis on conventional CT, but going forward, we may be able to grade it more precisely, like minimal, mild, or moderate, or severe stenosis, in-stent restenosis using these photon counting CT images. Recent studies have clearly demonstrated these advantages of photon counting CT. And as a brief talk, there is also the possibility of simulation, simultaneous multi-contrast agent injection when we obtain single CT scan, which allows acquisition of multiple phase information in a single scan using multi-contrast agent, multi-types of contrast agent, like this animal model. Photon counting CT can offer the following advantages: eliminating beam hardening artifacts and enhance the CNL. And it can also help to reduce contrast media dose and radiation dose. Molecular imaging with multiple contrast types can also possible. And simultaneous, multi-contrast injection also, yes, we can use. This slide is from Philips. It shows that with dual energy CT scan, and we can generate iodine map, iodine density map, and ECV map, like here, just with just one single scan. It also suggests that spectral CT can effectively visualize the late iodine enhancement, similar to how late gadolinium enhancement we previously talked, used in cardiac MRI, and very similar and very effective. So I expect that with next generation CT angiography, photon counting, spectral CT, and AI plaque volume and burden analysis, and maybe we can eventually be able to generate a detailed plaque composition like these coronary effects in the future. Yeah. In summary, with the rapid advancement of the CT technology, the field of cardiac imaging is undergoing a significant transformation. Thank you for your attention.